Okay, so good afternoon, everyone. Good morning, Richard. I'm Carolyn, and I'm a research fellow here at IPUR. So today I'm going to share about a project on type 2 diabetes. And this project really came together as an interdisciplinary effort, which involves clinicians from the National University Hospital, the School of Medicine, and also not forgetting our Deputy Director, Leonard. So I'll just give a start. Diabetes is one of the fastest growing health emergencies of the 21st century. Type 2 diabetes accounts for over 90% of diabetes worldwide. And figures, as you can see here from the International Diabetes Federation, show us the increasing prevalence of diabetes over the past decade. I picked out a few countries to illustrate here. And Singapore is taking the lead as one of the countries with the most concerning numbers, causing our Prime Minister in recent years to declare a war on this disease. So to set the stage, why the worry about diabetes? Firstly, the risk. Without adequate control, diabetes can cause serious damage to major organs over time. Second, what this requires is that individuals with diabetes have to make lifestyle changes. This requires a lot of self-care behaviors, including medication adherence, eye screening, food care, and so forth. But I think one of the greatest hallmarks of managing diabetes involves the patient navigating through a lot of setbacks, and we're staying not just for a few weeks or months, but usually over their lifetime. Patients face hurdles on an ongoing daily basis. They battle psychological and physical barriers. For example, increased conveniences, a lack of motivation to change their eating habits, or conflicts with their preferences or even their priorities, or discouragement when their blood glucose levels remain out of range. So when we took a step back, yes, there are current interventions to nudge behavior to get people to manage their health better, but we also wondered that whether could there be a more fundamental worldview in how patients with diabetes might be viewing or believing about their disease, which then colors their behavior. And this was one of the sparks that drove us really to probe into this further. So I thought to share this quote by Stanford psychologist Carol Dweck, as much of this underscores our work. The view you adopt for yourself profoundly affects the way you lead your life. And we believe that this extends to the context of healthcare, that people's beliefs about their health or about diabetes impacts the choices they make and affects downstream consequences such as health and blood glucose outcomes. So we had two overarching goals. First, we aim to understand the beliefs of individuals with type 2 diabetes, which is important since beliefs may not just influence people's perceptions of their health, but can also pose significant barriers to necessary self-care behaviors. And the second, with an understanding of what those beliefs are, we wanted to identify the appropriate beliefs for intervention work. And we feel that this is important because we want to make sure we're heading in the right direction before developing our interventions. So we first ran a preliminary study using cross-sectional design to explore a broad selection of beliefs and questions. Findings from that preliminary study helped us to funnel down to 3 focal beliefs to examine in the main study. I would love to share more about our exploratory study, but as we've only a short time today, I'm going to focus on our main study. So the 3 key beliefs we centered on here are locus of control, the fixed versus growth mindset, and self-efficacy. So just very briefly, broad definitions of what these 3 beliefs are. Locus of control refers to your belief about who controls the outcomes of things that happen. So people can have like a high internal locus of control where they think that they themselves are personally responsible for things that happen in their lives. Or they might have a high external locus of control where they tend to attribute responsibility to external people, things like authority, God, family members, or even to fate, luck, and so forth. People might also have beliefs about whether or not their attributes or conditions are fixed and cannot be changed, or whether they can be developed and improved. So we call this the fixed versus growth mindset. For example, taking it in a more academic context, some people, some children, myself included, may simply say that, you know what, we are bad at math. So those with a fixed mindset tend to believe that there's little we can do to change that area, and why bother, right? We show less persistence in trying to improve ourselves, and even worse performance after minor setbacks, while those with a growth mindset about their abilities persist through challenges, and they also take criticism of seeming failures well. Another belief that we wanted to explore is that of self-efficacy, which refers to one's belief about whether they have the ability to perform or execute certain behaviors in order to achieve a target or goal. So now our beliefs are usually directed towards some target. We have beliefs pertaining towards our general life. We also have beliefs about our work, our relationships, friendships, and even beliefs about our health. And in our survey, we actually asked participants to score their locus of control, their mindset, their efficacy beliefs, while thinking about their general life, and also on another set of questions about their general health. And we also wanted to go deeper and more specific at more nuanced levels. So we had specific instructions asking participants to, okay, maybe I should just show my laser pointer here, to rate their beliefs in relation to their blood glucose, their blood pressure, and their cholesterol. Because these three areas are concerns that doctors try to optimize in patients, we wanted to uncover if the beliefs of patients might pertain to these three levels, all three levels, or more specifically, only to blood glucose. And this would help us know whether we should direct our interventions or the way we communicate certain things to specifically beliefs about blood sugar, for instance. And also we wanted to extend our findings to health outcomes, for example, whether certain beliefs might reveal relationships with HbA1c, which is the glycated hemoglobin test used to monitor diabetes control. And finally, we wanted to run this study using full scales and original anchor points, which we didn't have the luxury of doing that in our preliminary survey. So we launched this study during COVID. It wasn't feasible to gain access to patients with diabetes through our local hospitals and clinics. So recruitment took place online. It was a very challenging process, lots of bottlenecks, but we managed to get almost 900 participants with diabetes and also participants without diabetes. So this allowed us to compare the effects of those with diabetes versus those without. So what we observed was quite interesting. On the locus of control scales, we found a mix of both low and high external attribution control. So compared to healthy individuals, those with type 2 diabetes tend to blame fate or chance less when it comes to their blood glucose control, their blood pressure, and their cholesterol. But they tend to attribute more responsibility to doctors and others in the areas of blood glucose and their general health. But then they also, people with diabetes reported having a higher internal locus of control compared to healthy individuals. So they seem to attribute more self-responsibility when it comes to managing their blood glucose and general life. So just to take a snapshot of what's happening here, we see a bit of a mixed bag of locus of control results across different health domains, between different dimensions of external locus of control as well. So we took a closer look at the literature, which some studies have cautioned about the stability of this construct, actually, suggesting that locus of control might not quite be a reliable construct to focus on in our interventions. Then we looked at mindsets, and we found that those with diabetes had less of a growth mindset, but fascinatingly only towards their blood glucose and not their blood pressure or their cholesterol. And then finally, we observed that those with diabetes had lower self-efficacy towards their blood glucose, cholesterol, and general health. And what this is telling us is that compared to those without diabetes, those with diabetes feel that they are less able to carry out behaviors to manage these areas. So we kind of start seeing a narrative where individuals with type 2 diabetes have more negative health beliefs pertaining to self-efficacy and growth mindset, where beliefs toward their blood glucose specifically seems to be surfacing as a common denominator of concern. So since our data showed that diabetic patients tend to have lower growth mindset and lower self-efficacy toward their blood glucose, we wanted to understand the relationship with HbA1c, which is the blood sugar level. And this analysis was done only amongst diabetic participants. And what we found was intriguing. Our data actually revealed curvilinear negative relationships between growth mindset and HbA1c, and also negative curvilinear relationships between self-efficacy and HbA1c. So the greater the growth mindset score, you can see on the axis, the higher the numbers, the lower the blood sugar level, as long as this is below a certain threshold, right? Beyond the threshold, for example, 7.8, which I marked out in the chart, we see minimal change in A1C as mindset improves, which could indicate something like possibly diminishing returns or kind of a ceiling effect. Similar results when we plotted self-efficacy with blood glucose. So we can see that on a 6-point growth mindset scale, where 1 is a more fixed mindset and 6 is a more high growth mindset, once growth mindset hits 4.78, which is quite a desirable growth mindset score, it might not be fruitful to increase growth mindset since improvements in mindset no longer leads to further reductions in blood glucose. But knowing the turning point gives us an indication of the patient segment we could focus our intervention on. And another look at our data showed us that a 64% majority of patient participants score below this turning point. And then for the self-efficacy score, over 92% of our respondents with diabetes score below this 4.59 turning point of self-efficacy. So what really stands out to us in this study is that the findings seem to support observations from the doctors in our team, where they hypothesized that there might actually be a negative cycle between poor blood glucose control and mindsets or health beliefs, where one feeds off the other. So patients with high blood glucose tends to also have more fixed mindset towards managing their health, and this fixed mindset then hinders them from engaging in necessary self-care behaviors, and it manifests again in a poor blood glucose control thing, and the vicious cycle goes on. So what we can do really is to break this cycle. So these are exciting results that show great potential for work in the area of developing psychological interventions to speak into these moods. So moving forward, we are working on studies to understand healthcare providers, what are some of the challenges they face, their perspectives towards this mindset concept, and also perhaps understand their perceptions toward patients who might seem stuck in managing their disease. Do doctors themselves perhaps have a fixed mindset towards interacting with some of these patients? And we also wanted to work on developing some of the groundwork for interventions for the patients themselves, and also to understand what their needs and concerns are with managing the disease. So we are excited to report that we've secured 2 seed grants to support both arms of this project, and we are really looking forward to getting a deeper grasp of how we can tackle this